Direct pressure. You have 7 minutes. That is not a metaphor. It is the clinical window between uncontrolled arterial hemorrhage and irreversible shock in a healthy adult at rest. When the grid goes down and no ambulance is coming, the first question is binary. Is the bleeding visible and reachable? If yes, your hands are the only hemostatic device that matters right now. The physics here are not complicated, and they do not require a medical degree to apply. Sustained external pressure applied directly over a bleeding source reduces what trauma surgeons call transmural pressure, the differential between pressure inside a damaged vessel and pressure outside it. Drop that differential far enough, and the low-pressure venous bleeders and smaller arteries collapse on their own. That is hydraulics, not magic. What you are doing with your palms is not passive holding. You are actively reducing the driving gradient that is forcing blood out of that vessel with every heartbeat. Harder, direct, centered over the source, not over the bandage. While you hold, the coagulation cascade is running in the background. Platelets contact the damaged endothelial surface and activate. Fibrin threads start cross-linking. In a clean puncture or laceration with sustained pressure, minimum 3 minutes without breaking contact, you are giving the intrinsic pathway of coagulation time to build a stable clot. Lift the dressing to check, and you reset that process from 0. Every single time. This is not a suggestion, this is the mechanism. The clock restarts the moment you lift. This is the oldest battlefield hemostatic technique in documented medical history. Field dressing protocols from both world wars relied on exactly this principle, not because no alternatives existed, but because it works and preserves blood flow distal to the wound. Unlike mechanical occlusion devices that shut off limb circulation entirely, direct pressure stops the leak without starving the tissue below the injury. The trade-off is time and consistent manual force. If you can hold 5 solid minutes with the right improvised material, a folded shirt doubled over, a rolled bandage, any clean, dense fabric, you have already cleared the hardest initial hurdle in trauma management. If you have already drilled hemorrhage control and this is review for you, drop a comment below. It helps surface this to the people in your network who have not. The reason the next item comes second is not because it is a better technique. It is because there is a specific scenario where holding a wound is not enough, and that scenario arrives fast. Tourniquet. The first time I applied one under real-time pressure, not in a controlled training environment, but on an actual limb, my hands stayed steady. My thinking did not. There is a deep wired instinct against cutting off circulation to an extremity. That instinct, in an arterial bleed, will get someone killed. The physics do not negotiate with feelings. When hemorrhage is arterial, bright red, high volume, pulsating with every heartbeat, direct pressure is buying seconds, not minutes. A major limb artery at systolic pressure can drain a limb's blood supply in under 3 minutes. The only mechanical intervention that reliably interrupts that process is circumferential compression exceeding systolic arterial pressure, typically above 120 millimeters of mercury for most adults. You are not slowing the bleed. You are eliminating the pressure gradient that drives it. No gradient, no flow. That is the entire mechanism. I keep a product placeholder combat application tourniquet within immediate reach, not buried in a bag. The application protocol is high and tight, as proximal on the limb as physically possible, 2 to 3 inches above the wound minimum. Windlass or ratchet, turned until the bleeding stops and the distal pulse is gone. Then you write the time of application on the device itself or on the casualty's forehead in marker if nothing else is available. That timestamp is the critical data point the surgeon uses later to make the reperfusion decision. Lose that timestamp, and you lose the clinical context that determines whether the limb survives. The ischemic risk is real. Every minute past 2 hours without reperfusion increases the probability of permanent tissue damage. But the alternative is a casualty in hemorrhagic shock with no circulation reaching any organ. Stay rational. The tourniquet is not the problem. The hesitation before applying it is. The communities that train for grid-down scenarios understand this distinction, and it shows in their outcomes. Where direct pressure and tourniquet application both reach their limits is the third scenario. A bleed that sits too deep, too proximal, or in an anatomical location that makes circumferential compression mechanically impossible. That is where the next protocol separates the prepared from the unprepared. Hemostatic packing. This is the entry that changes the triage decision tree in ways most civilian training programs have not caught up to yet. Junctional wounds, groin, axilla, neck, pelvis, are beyond a tourniquet's mechanical reach by anatomy. A high femoral artery bleed at the inguinal crease cannot be occluded circumferentially. An axillary vascular injury cannot be compressed with a limb device. In those locations, before surgical access is possible, the only intervention with documented efficacy is wound packing with a hemostatic agent combined with sustained manual pressure over the packed cavity. The mechanism operates on two simultaneous layers. The physical layer is mechanical tamponade. Tightly packing the wound cavity with gauze physically fills the dead space and creates resistance against the pressure driving blood outward. That alone increases clotting probability. The biochemical layer is what separates military-grade hemostatic gauze from standard gauze. Colon-impregnated gauze, the chemistry behind product placeholder quick clot combat gauze, functions through surface adsorption of coagulation factors, specifically concentrating and accelerating the intrinsic coagulation pathway at the factor II activation point. Chitosan-based products like product placeholder Hemcon bandage operate differently. Muco-adhesive binding to the platelet surface drives direct aggregation independent of the enzymatic cascade. Both approaches biochemically short-circuit the propagation of blood flow at the wound site. The gauze is not passive filler. It is an active participant in the clotting process. Technique execution matters as much as the agent chosen. Packing requires direct finger insertion all the way to the base of the wound cavity, and the cavity must be packed tightly without air pockets. Half-packed at arterial pressure is functionally equivalent to unpacked. Sustained pressure over the packed wound for a minimum of 3 minutes follows. Not 30 seconds, not until your hands are uncomfortable. 3 minutes minimum. Prepare in silence. The blood is not the emergency. Uncontrolled progression of volume loss over time is the emergency. This protocol is grounded in Army Institute of Surgical Research data from the early 2000s and is now embedded in tactical combat casualty care globally. The full reference breakdown and a printable trauma kit checklist are linked in the description. Use them. Before the grid fails, make sure the actionable intel is in your hands. Subscribe to Urbanalypse now and activate the notification. Every protocol in this channel is sourced, structured, and ready to use before you need it. Airway Control. If the person in front of you is not moving air, every other action stops being relevant. Hemorrhage management, positioning, kit deployment. None of it extends survival past 4 to 6 minutes if oxygen is not reaching the brain. This is not the scenario to improvise without drilling the mechanics first. 2 primary maneuvers require no equipment. Jaw thrust. Place your fingertips behind the angles of the mandible and displace the jaw anteriorly, forward, without extending the neck. This is the protocol when spinal injury is a possibility, because forced cervical extension in an unstable fracture can convert a survivable neurological injury into a complete cord transaction at the injury level. Head tilt, chin lift. For a non-trauma casualty or when spinal compromise is ruled out, tilt the head into extension, lift the chin upward, and open the posterior pharynx mechanically. Both maneuvers operate on the same airflow principle. They restore laminar air movement through the upper airway by physically widening the pharyngeal lumen. An obstructed airway is not an airway. It is a dead end under pressure. Clear visible obstructions first. Finger sweep if the casualty is unconscious and debris is reachable. Remove whatever you can see. If those maneuvers restore breathing, stay there. Do not move the casualty. Do not switch approaches. If the jaw thrust and chin lift do not produce chest rise and air movement, if repositioning the airway does not restore ventilation, the upper airway is not the problem. The problem is anatomically below it, and the field solution for that is surgical. Cricothyrotomy is the fastest, most anatomically predictable emergency airway available without operating room infrastructure. The anatomical access point is the cricothyroid membrane, the soft tissue gap between the thyroid cartilage, which is the firm ridge you know as the Adam's apple, and the cricoid ring sitting directly beneath it. Locate it with a finger pressed down the midline of the anterior neck. You feel a ridge of cartilage, then a slight depression, then another firmer ridge below. That depression is the entry point. A horizontal incision, a dilating finger to open the lumen, and a tube, a commercially available emergency airway device or an improvised tube of comparable diameter, establishes a direct pressure-driven gas exchange path below any supraglottic obstruction. Severe swelling, anaphylaxis, crush trauma to the face and jaw, a foreign body that resists clearing, all bypassed in one access point. Stay invisible in how you carry this knowledge. You do not announce it. You do not wear it. The people in your environment do not need to know what you have drilled. You do. The difference between this field procedure and a tracheostomy is not only anatomy, it is operational time. Tracheostomy is a planned surgical procedure with sterile field requirements. Field cricothyrotomy is a 2-minute analog backup for a biological system that just failed. The airway maneuver checklist and field kit build are linked in the description. Do not drill improvised techniques without mapping the anatomy first. What comes after the airway is the fifth and most counterintuitive failure mode in this sequence. One where the lungs are structurally intact, the airway is open, and the casualty is still dying. The fix takes a needle, a precise anatomical address on the chest wall, and about 30 seconds of correct execution. Needle decompression. The first time I worked through the full physiological timeline of a tension pneumothorax on a real pressure curve, the detail that registered hardest was not the mechanism, it was the speed. Air enters the pleural space through a penetrating chest wound, a fractured rib that lacerates the pleura, or blunt force that creates an internal tear, and a one-way valve effect traps it there. Each breath draws more air into the pleural cavity. None of it can escape. As the pleural space fills, the lung on the affected side collapses progressively. Then the pressure differential shifts the mediastinum, the entire central compartment of the chest containing the heart and great vessels, laterally toward the opposite side. That mechanical shift compresses the contralateral lung and kinks the superior and inferior venae cavae, obstructing venous return to the right heart. Cardiac output drops. Blood pressure falls. The casualty dies from cardiovascular collapse with 2 anatomically intact lungs. The lungs were never the primary problem. The pressure gradient that eliminated the heart's filling pressure was. The intervention is immediate, a needle into the second intercostal space at the mid-clavicular line or, per current tactical combat casualty care evidence, the 5th intercostal space at the anterior axillary line using a longer gauge catheter, which shows higher decompression success rates in larger or more muscular individuals where chest wall thickness reduces the effectiveness of the traditional site. A 14-gauge catheter of at least 3¼ inches minimum is the current pre-hospital standard for the lateral approach. The needle pierces the parietal pleura, and the trapped intrapleural gas escapes instantly. A rush of air confirms placement. Negative intrathoracic pressure is restored. The mediastinum shifts back, venous return resumes, cardiac output recovers within seconds. This is not definitive repair. A chest tube is the definitive intervention. Needle decompression is a temporizing bridge to that access, bought with 30 seconds of correct execution. That distinction matters because the temporizing step is what keeps someone alive long enough to reach anything definitive. I carry a dedicated catheter in my trauma kit because the skill without the hardware is still just knowledge. If your kit does not have one yet, the complete build, the full pre-hospital trauma protocol running from direct pressure through this decompression step is in the Urbanalypse archive. 5 actions, 5 pressure gradients, skin surface to chest cavity. The physics do not change, the 7 minutes do not negotiate, the preparation does not expire.